Sir, for examination, I will like to assess the airway breathing circulation of the baby and what is hydration status, whether and any cyanosis is present or not. As I can see, there is no cyanosis at present. And without much disturbing the baby and uh, keeping the patient calm, I will ensure that while doing the examination. Hello?
Hello.
Yes, sir.
Okay. So consider a differential of group. How would you like to manage this patient?
So for management of group, I would like to classify the patient based on the degree of his distress, alertness, and cyanosis. And if it is mild to moderate group, I would give an I will ensure oxygenation. If oxygen is normal, then I will give analgesia and ensure its feeding. If required, IV fluids and oral dexamethasone need to be given, and then the baby should be reassessed after 4 hours. And if the baby is fine, then we can discharge the baby. And if the severity of the group is if the disease is more severe, then I would like to inform the PICU team, consultant, pediatrician, along with anesthesiologist and ENT specialist. Uh, and I would like to hospitalize the child, give oxygen via nasal masks, give IV fluids, and give dexamethasone oral or nebulized budesonide. Hello?
Hello.
Yes, sir.
That this is going to be an acute
Yes.
event.
Yes, sir.
And that the sudden.
Sir, your voice is breaking. Hello? Hello?
Audible or
Sir, your voice is breaking.
in between?
Yes, sir.
Okay. So is it audible now?
Yes, sir, it is audible now.
Okay. So in the case of scenario that, say for example, if this child has an acute sort of lasting for the last few hours,
Yes.
what is the one important issue you want to write for the mother as an ST3 candidate?
I would like to ask about, sir, foreign body, any choking or drooling episode, and
Okay, doctor. Thank you.
yes, sir. Thank you.
It's open to feedback. Others, would you like to add anything in the history apart from whatever doctor has described? Hello. So open to discussion. Others can participate. If there is anything you would like to add in the history.
So, history of viral infections. Anyone else in the home having flu? Does the child go to daycare center? Vaccination history of the child.
So why vaccine is
Pertussis, whooping cough.
that's one. But they used to say that I can cough, and if the coughing is continuous, then what is the differential you would like to offer? Upfront is
Whooping cough.
whooping cough. Okay. So many times the whoop may not be that much very classic, but if the cough is continuous, then uh, the differential, one of the differential is whooping cough. Okay, so vaccination history. Anything else?
History of allergy, asthma in family.
Okay. So any contact history is important. Apart from this hemangioma and other things, there could be a family history. Okay. And if it is going to be episode, as I always say, if there is going to be episode, you always start with the event. Okay. So you how it all begin, whether it is going to illness. And difficult doing before this, and is it lasting for how many days, and is there is a continuous cough, is there is any post cough vomiting, is there or not? Okay, all these things, and contact history, if there's any missing toy. If it is going to be a preschool child in age group of 1 to 5 years, then missing toy history is very important. And obviously vaccination history and contact history is important, right? Okay. And what is the examination finding you will get in this case? Dr. Motion? If it is going to be group,
Sir, on examination, we need
what
not
sort
to,
of stridor you are expecting? A group in classically in group.
is inspiratory strider, sir.
Pardon?
Inspiratory strider.
Inspirator stridor, right? Okay. So that's very important. Okay. And regarding the management part, you have to divide it as whether it is mild, moderate, or severe. Okay. In general, what is the observation time as per the RCPC guidelines for any child coming to OPD?
Sir, 4 hours.
4 hours is the observation time. Okay. So the as per the guidelines, what is the starting drug?
Dexamethasone.
Yes. Dexamethasone. If in case the child is not able to take oral, what is the next choice then?
Sir, to admit the child and start IV fluids after seeing urea and electrolytes.
Hmm.
And we can start with nebulized adrenaline and give oral dexamethasone or nebulized budesonide.
Okay, so Nebulized adrenaline is a choice, okay? In case the child is not able to take orally, then the next choice is nebulized adrenaline, okay?
Yes.
And want to give to the mother.
Advice to the mother regarding if after going home, if the child has increased work of breathing, develops apnea or cyanosis, or there
So you
is
will
a
say difficulty in breathing, okay?
yes, sir.
Difficulty in breathing or the increasing in severity,
Yes,
okay? And the child is not able to take, if the child is taking less than the usual feeds, less than 75% of the usual feeds,
yes,
okay? And if there is any drooling, okay? Warnings.
yes,
The closed differential is epiglottitis, right? So if in the video the
yes,
child has drooling, then epiglottitis is
yes,
one of the closest differential, okay? Right.
yes.
And just for the discussions, ask you about differential other causes of SIDA.
Sir, your voice is breaking.
Breaking, sir.
My gosh. So if they ask you about what are the apart from epiglottitis and ALTB, how will you like to answer that question?
Subglottic
Sir,
stenosis.
depending upon the onset, sir, if it is chronic, then first differential will be laryngomalacia,
Mm.
and then other causes like subglottic stenosis, laryngeal papilloma, laryngeal hemangioma, and again foreign body and hypocalcemia also can be considered.
Okay. So okay, fine. So the other way whether it's extrinsic compression or whether it is a problem with the wall, the pipe. Okay. So
Yes, sir.
intraabdominal causes could be hemangioma, papilloma, web. In the trachea, the problem could be vascular. Sometimes post extubation, all these things, granulation tissue, this could be reason. And the extraluminal compression will be some nodes or any mass which can compress the airway.
Yes,
Okay, so acute SIDA, what are the causes? Then acute SIDA, the first thing is you want to say the most commonest group, and the
epic.
red flag you want to roll out is acute epiglottitis. Okay,
Yes, sir.
so if you get it and rule foreign body, anaphylaxis,
Yes,
retropharyngeal
sir.
abscess, these are all acute causes. Okay, particularly the child is sick looking, you have with fever, then three differential is acute epiglottitis, tracheitis, and retropharyngeal abscess. Okay, and no fever, then for good differentials with acute and sick child. Okay, group is the best differential. Okay.
Yes, sir.
Any doubts with this video? Others? Others? Hello.
Sir, your voice is still breaking, sir.
Um,
Sir, with acute condition and fever, you said acute epiglottitis. retropharyngeal abscess, and the third one, what's that?
Tracheitis,
Can you
bacterial
repeat?
tracheitis.
Okay, yes, yes, bacterial tracheitis. Yes, yes. Thank you.
So there we have a sick child with stridor and acute cause, right? With fever.
Yes, yes.
Without fever, then you can think of foreign body and anaphylaxis as well. Thing is, in history, you will ask questions pertinent to rule out anything which is very serious. Okay, so your history should be focused. And then obviously the history for the obvious cause, which is group. To the next video. Shall I go to the next video? Any doubts with this?
Sir, if the examiner asks us about what examination will we do, then do we have to tell all the steps of the respiratory system examination, like chest
No,
expansion?
no. Always
No.
as you did. Two minutes will be over. Then as you talk about the history and examination, is my audio clear now? Showing
Yes,
some
sir.
stable voice. Okay, fine. Thank you.
Right now it is clear.
Oh my God. Okay. Okay, clear?
Yes, sir, it's clear now.
Fine. Okay. See, as you describe the video, it will take 2 minutes. Okay. And then you have 2 minutes to talk about the history and examination. And then the clue comes after that. Okay, so you will not have time to take detailed history, detailed examination. Okay.
Yes, sir. Okay.
Fine. Shall I go to the next video?
Yes, sir. Let's go to the next video.
Who wants to try the next video?
Sir, shall I try? Lakshmi
Okay.
here.
Okay, fine. Are you able to see and hear it?
Yes, sir.
Yes, sir.
Yes. The time starts.
What do we? Hello. 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 Hey, you want to talk? What do we? Hello. 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 Hey, you want to talk? What do we? Hello. 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 Hey, you want to talk? What do we? Hello. Hello. Hey, you want to talk?
Shall we start?
Yes, sir.
Oh,
So, I happened to see a video with a child, probably an infant, with in a he's a stable child and he's in a seated position, probably in a home setting. So I can see that he doesn't have a respiratory distress and his dimension seems to be normal, but I would like to plot. And there is some dysmorphic features in the form of widely spaced eyes, frontal bossing, and also small short nose and widely spaced nose, and also I could see the retrognathia and lowset ears. So, and also I could see that there is a device attached to the child's neck, tracheostomy with the tube. So yeah, and the child is being cradled by probably his sibling, and the child seems to be seems to be pleasant with no there is no obvious cyanosis or pallor, and child's breathing sound seems to be obvious. Probably some secretion is there.
okay. Okay, Dada. What are the things you would like to ask in the history?
So I would like to start asking by like when was the first time this procedure was done, and what was the reason for the procedure, and also who all were like, how are they maintaining the equipment, and are they getting any support regarding maintenance of the equipment like in trachiness and pulmonology support, and also and also I would like to know whether they are changing it changing the inner tube frequently. I would also like to ask whether the child had any yeah, any history of any if the history suggests of any acute respiratory distress and throat congestion or anything like that leading to the procedure. And also, I would like to ask about other complications associated with the tracheostomy, and whether the child has developed anytime cyanosis or loss of consciousness or seizures, anything like that. And also, I would like to ask in detail about his birth history, whether any abnormality was detected in the antenatal scans or aneuploidy screening, or also any procedures. Mother having a history of any drug intake or alcohol at that time. Also, I would like to ask about postnatally whether the child was detected to have the problem with breathing, and tracheostomy done at that time, any respiratory distress at that time, any procedure done at that time. And also, yeah, I would also like to ask whether any genetic test was done, any syndrome suspected on genetic test done for this child. And also, I would like, yeah, I would like to ask about the vaccination for this child. And also, since this appears to be syndromic, I would like to ask whether any other child in the family also having similar features.
Okay, doctor. So, me too, right? So, what are the indications do you think
Yes,
this
sir, the
child?
indications are this. Okay, so airway protection is mainly, and the two probably airway protection as well as respiratory support. But in this child, I assume it is for airway protection. Because of the probably due to the tongue falling back or causing airway obstruction, or needing the tracheostomy. So it could be a subglottic stenosis or any neuromuscular weakness for this child, or additionally also any other airway problems causing, I mean, leading to this airway obstruction. And also I like to think of GERD also. Probably.
Okay. Okay.
Syndrome.
What are the other indications for tracheostomy apart from what I have talked?
Yeah, so it could be like whether in case of trauma, like in a road traffic accident or any neuromuscular weakness, there could be a SMA like that. And also, if there is obstructive sleep apnea, there is a need for a tracheostomy. And if there is severe GERD, sir, and if there is need for prolonged intubation in the child.
Okay. Okay, doctor. So, what are things you like to emphasize while taking care?
Sir, what are the
What
points?
are the things you like to emphasize while taking care of a tracheostomy?
So, tracheostomy, uh, tracheostomy, there should be a kit. They will be provided with a kit for the regular change of the tubes, and also they should look for any local skin infections or any dislocation of the tube or any obstruction of the tube, and they may have to do the clearing of the obstruction. And if it is dislocated, then they may have to rush to the hospital. And also, if there is an infection also, they have to get medical advice.
Okay. So, what are the complications involved in tracheostomy for a child
The
who's having
complications,
tracheostomy?
yes, the
Yeah.
complications could be obstruction, dislocation, and nearby skin infection and bleeding, and also yes, and also um, yeah, and ulceration of the site.
Hello.
Yes, sir.
Yes, doctor. Thank you. Okay, time up. Okay.
Yes, sir.
Right. Others, it's open to discuss in the history and in the differentials for tracheostomy.
Sir, in history, she covered most of the things. We could still add, like, when was the tracheostomy done? Why was it done? Was there any interventions done? Was the child intubated before? Any operations done before the tracheostomy? Did they do any DLTB or any airway surgeries or anything? And how many times the child was admitted with a respiratory infection? And how many people in the house are BLS trained? Do they have a tracheostomy nurse who is named for them? Who is their respiratory consultant? Who is their ENT consultant? How are they coordinating care? Do they have a trachea nurse? Do they have care support?
Okay. So to start with, you can ask like whether it is going to be acute event requiring this or is it on the long time. Okay. So the duration will decide upon the indications and other things. Okay, regarding the tracheostomy care, anything else to add as an ST3?
The education of the parents regarding
Mhm.
if there is
So
any change in the
return
of circulation.
tracheostomy plan should be given to the patient. Okay, so that's that they do. So return tracheostomy plan is the cornerstone for the management of the tracheostomy tube, and then you have to tell about the inspection of stoma, whether how to take care of the ties are secure and how to take care of the tube, to check whether the tube is secure. Okay, and regarding this humidification, they will have this HME filter, okay, for the humidification, and suctioning when it is when there is an audible secretion. All these things should be advised as an ST3 level for the care of tracheostomy. What about complications? Anything else apart from what Dr. Lakshmi has mentioned?
Arrhythmias and hypoxia.
Yes.
Sir,
Arrhythmias and
obstruction,
hypoxia.
bleeding during suction, arrhythmias, pulmonary embolism, then local tissue skin necrosis, bleeding.
Mm.
Then dislodgement.
Mm. Okay.
Yeah, sir. During suction, pulmonary embolism, arrhythmia, and dislodgement, obstruction, bleeding, local tissue skin necrosis.
Okay.
Yeah, yeah, sir.
So see the complications you can divide as the methodology can divide as the early and the late complications, right? So early complication could be bleeding, subcutaneous emphysema, or even pneumothorax, Ehrlich syndromes. So all these Ehrlich syndromes, malposition, obstructions. These could be early. Okay. Late could be infections, and then this tracheitis, then obstruction because of the granulation tissue, and
Okay, sir.
close after this decannulation. So tracheotomy fistula. Tracheostomy, they will have difficulty in speech and things, right? So these could be long-term complications. Okay, and the indications, again, that could you can divide if you want to divide the indications, you can divide as acute and chronic indications. The acute indication is ventilation. So patient on ET ventilation for a long time, then 3 to 5 days time, then they will change over to tracheostomy. And any head and neck tumors requiring surgeries, they will put to this tracheostomy, right? That's an acute indication. And chronic indication, craniofacial anomalies. Okay, so Dr. Lakshmi, you described neatly the whatever you have observed. So all those retrognathia, low TS, those are all perfect. Okay, so craniofacial anomalies and indication, structural anomalies, any structural anomalies, including all these craniofacial anomalies, laryngomalacia, tracheomalacia, vocal cord paralysis, subglottic stenosis, all this could be an indication, as a structural airway indication for tracheostomy, right? And the other group is this neuromuscular disorders where you want to reduce the work of breathing as well as you want to have this pulmonary toilet, this like when it has a difficulty in clearing the secretions. So there you can have a long-term tracheostomy. Okay. So tracheostomy has been repeating multiple times in the last 1.5 years. Okay, even the last session it came in India. So indications, care, and complications. Okay, so try to like in group, you can divide it as like acute indications and chronic indications, and as well as complications. Okay. Any doubt with this tracheostomy? So this child is an syndromic child with a craniofacial anomaly.
Sir,
Sir,
how
your voice is breaking.
In short, okay. So
Sir, we didn't hear, sir, what you are telling.
okay,
Like for.
right, fine. So any doubts with this?
Sir, how will we ask about acute and chronic history? Will we ask from the attendant, from the mother, that what is the reason
Whether
for
how
doing?
long is the child is on? The first question will be how long, la? In case if the
Okay.
child is on tracheostomy, how long is the child is on tracheostomy? Sit.
Okay. And
Sir, again your voice.
It's gone in between.
Yeah, we cannot hear. Actually, two questions we don't know. We don't know what you answered, sir.
Which question? Please
The
repeat.
one before also, you were telling something. That also.
Regarding indications of tracheostomy.
No, that is now.
Okay.
Yeah, indication. Yeah. In between
Complications of
also.
tracheostomy are clear.
Yes, sir.
Want to divide into early and late. Okay.
Okay.
And regarding care of tracheostomy, is that
Yes,
clear?
sir. Can you? No, sir.
Okay.
Care of
Okay.
tracheostomy.
So first thing is you have to have a written tracheostomy plan. Okay. That is one. Okay. As well as you give this plan to the mother when you are trying to discharge the child. Okay. The first thing is inspection of the stoma. Second will be the straps on the sides. Okay. That is the ties. And securing whether the tube is in position or not. Okay. As an ST3, you will ensure all these things are being done while in ward, as well as you will teach the mother. And always humid. So you
Always
can humidification.
humidification.
Yeah.
Okay.
So they use an HME filter. When there is an audible secretion, audible sound is there, then okay.
Then
Suction.
sir, audible sound. Then okay.
Suctioning should be done. And in case of any increase in difficulty in breathing, then they have to come to the they'll have this tracheostomy nurse number, and then they will be like advised early access to the hospital.
Okay. Sir, any investigations for this, sir?
No investigations. This is something like an sort of an instrument, so there is no investigations like here. So here it will be the questions you asked in the previous examination was like what are the indications and what are the things you will advise the mother and what are the complications you expect and what is the team you would like to have for tracheostomy.
Consultant pulmonologist, tracheostomy nurse, and chest physiotherapy,
ENT.
dietitian, ENT, dietitian.
Okay. Right.
So can you repeat that? Team.
Shall we go to the next one?
Sir, somebody was asking to repeat the team, sir. We cannot hear you, sir. This pulmonology,
respect.
tracheostomy nurse, just physiotherapy or consultant, then ENT, then dietitian.
Right.
Tracheostomy
was
nurse
the
is there, no, sir?
Pardon?
Tracheostomy nurse.
Yeah. She mentioned it.
Okay.
Sir, what was the relation with pulmonary embolism? How can it cause pulmonary embolism?
Pulmonary embolism for which one? This year.
In trachea, somebody was saying that it could cause pulmonary embolism. I couldn't quite
No. I think they mentioned about pulmonology.
Okay.
So this video is about okay. Shall we go to the next one?
Okay, sir.
Who wants to do the next one? It's open to all.
Sir, shall I present?
Your name, doctor?
Dr. Annu.
Is the audio and video clear?
Yes, sir.
Shall we start?
Sir. Sir, in this video, I can see an infant lying down in a couch with an obvious dysmorphism. His baby is in respiratory distress with noisy breathing, crying. A pacifier is attached to his mouth. There are no other devices attached.
The baby has respiratory distress in the form of tachypnea as well as subcostal intercostal retraction, and his growth appears to be normal. So is considering these things, I will consider my differential diagnosis as bronchiolitis, some viral induced wheeze, pneumonia, foreign body.
Okay. So what are
Um, Hello. Hello.
yes, what are the things you like to ask in your
Yes, sir.
history?
Sir, I will ask the onset of the symptoms, how the breathlessness, the distress, how it is acute or is a chronic case, as well as the any history of any preceding fever or rhinitis or coryzal symptoms before this, history of any missed toy, history of similar illness, any viral infection or any other infections in the family, mm, family history of bronchial asthma. Then hello.
Yes, proceed.
Yes, sir. Sir, that will the questions that will I would like to ask, sir.
Okay. So what are the things in the examination you like to follow?
I will do a complete examination of the baby, including a respiratory system examination. I will look for any the respiratory focal signs or it is diffuse symptoms. An audible wheeze is there. Is it a focal? If it, then I will consider then pneumonia or a foreign body. Then I will do an SpO2. I have to look for any desaturation. If it is less than 90%, I will give supplemental oxygen. Then if the baby is in severe distress in cyanosis or if the respiratory rate is severe more than 80, then I will consider taking a capillary blood gas also.
Okay.
Then if there are localizing signs like crepitations in one side, or there is a severe pyrexia, then or any cardiac non-case of cardiac disease or anything or murmur, newly heard murmur, then I will ask for to take chest X-ray.
Okay. So considering as a case of a bronchiolitis,
Yes, sir.
okay, what are the precautions you would like to take as an ST3 in managing this child?
Sir, if it is bronchiolitis, then there can be an underlying viral infection. So I will ask the baby to be nursed in a cubicle. If there are similar cases of bronchiolitis, I will similar babies will be kept in a cubicle. Then I will ask the staff and doctors who are taking care of them to follow strict hand hygiene. Then
Okay.
okay, sir. Then
Anything else you will take precautions? What are things you like to monitor in this child?
I would like to monitor saturation, SpO2, the ongoing if there is a distress, the respiratory status, respiratory severity, now on a 4-hourly basis to look for worsening of symptoms, to find new onset symptoms. Then any cardiac, if there is any features of any cardiac illness, then I will ensure adequate fluid intake. If the baby is stable enough to take oral fluids, then oral fluids. Otherwise, if the baby is a cough and distress is compromising the intake, then when I will ask either NG, nasogastric feeds. If the distress is severe enough, if this respiratory acidosis or anything, then I will continue. I will start IV fluids after sending urea and electrolytes. If the if Hello, sir.
Yeah, in the case that you are discharging this child, what are the things advice
Okay.
you like to give to the mother?
If the baby is stable and fit enough for discharge, I will ask the mother to continue monitoring the baby to look for any respiratory distress, like respiratory like retractions, cyanosis, or increasing fever. Then I will ask the mother to come again and consult the emergency. Then
Okay.
one thing I will do is if there is a chance of if there are pregnant women or elderly individuals in the family, I will suggest them to take the respiratory syncytial virus vaccinations as a prophylactic measure.
Okay. So what
Hello.
are the indications to admit this child?
If the babies has severe distress in the case of cyanosis, the severe desaturation, SpO2 is less than 92%, non-case of any congenital heart disease or non-case of any chronic disease like cystic fibrosis, then I will suggest to I will admit the patient, baby.
Can we say?
Yes, sir.
Right. My feedback is I think you have covered most of the things. Maybe one of the differential cystic fibrosis you can include.
Okay, sir.
Okay.
Okay,
Sir,
sir.
was there audible wheeze with grunting in the video?
Pardon? In the video?
Was there audible wheeze with grunting in the video?
Yes, yes, yes. Okay. And what is there in the mouth?
Is it a pacifier, sir?
And was there any oxygen?
NG tube was there.
Okay. So there is a tube in the nose. Okay. So
Okay, sir.
Oral airway. Oral airway.
no, it's not oral airway. It's a pacifier.
Pacifier.
Okay. So the general cause disturb the child. Okay. So you will precaution like as an ST3, you will whatever thing mentioned, like you will nurse along with similar children and hand wash hygiene, and particularly heads up. Okay, the head should be somewhat elevated, head and chest. And you will monitor the respiratory rate saturation, and the child is not able to take oral feeds, or you think there's chance of aspiration, you will tend to give 80% as an IV fluids. Okay. You will not give full IV fluids. And if there is any persistent vomiting, low saturation, you tend to give IV fluids. Okay. And the oxygen should be humidified oxygen, warm and humidified oxygen, right? I think history part, you have covered most of the things, and the differential we can offer here is apart from bronchiolitis, you can say it could be the initial part of cystic fibrosis as an ST3 to have one bad differential. And obviously, other
Yes, sir.
differentials could be if there is a cough, then pertussis, infant cough, pertussis is again a differential, grunt, cough, and
Yes, sir.
viral triggered wheeze.
Okay,
Viral
sir.
triggered wheeze could be a
She did she ask prematurity history and history of DTD,
2%.
sir?
Yes. And
Hello.
child taking less than 75% of the feeds, or child is dehydrated.
Okay,
And
sir.
with any systemic illness, heart disease or lung disease, would be an indication for admission.
And sir, the last question, the answer for the last question which you asked at the time of discharge.
Advice to the mother, right? Advice to the mother during discharge, right?
Yes, yes, advice to the mother at the time of discharge.
Okay, so
What will be
she
the
should
answer?
come back. She should come back if the feeding is usually less than the usual half of the feeds, less than 50% of the feeds, and there is no wet nappy for last 12 hours. There is worsening of difficulty in breathing, or the child is turning blue or looking exhausted. She should come back. Okay, and she should avoid exposure to passive smoking.
Yes, sir.
These are few advices we can give to the mother with taking care of a child with bronchiolitis.
Sir, wet nappy for how long? No
12
wet
hours.
nappy for 12 hours.
12 hours and more.
Okay.
So bronchiolitis, the questions which have been asked multiple times in the various sessions, one is the indication for admission. Okay, so it is very specific. Okay, 3 or 4 specific indications for admission. And what are the precautions you will take in managing this? So you tell about nursing with similar children and hand hygiene and head position, monitoring respiratory rate saturation and monitoring the hydration status, and you tend to give some 2/3 of the requirement, right? So that is one, and you will tell about this warm and humidified oxygen. Okay. Anything else? Any doubts with this?
So can you repeat the indications for
Apnea.
admission?
Indication one is apnea, recurrent apnea. Any child who is having congenital heart disease or underlying lung disease, saturation less than 90% or 92% in case less than 6 weeks. More than 6 weeks, it is 90%. And child is not taking the feeds, not able to take feeds or fluids, less than 75% of the feeds, or child is dehydrated. Okay, so apnea, hard, you can remember like apnea, underlying disease, saturation, low saturation, less than 90 and 92%, and child is having dehydration or not able to take feeds. 2/3 of the feeds. Okay. Any doubts here? Hello.
No, sir. Thank you.
Yes, sir.
Right. Okay. Can we have one more video? Like anybody wants to try this next video?
Can I try, Amulya?
Yeah, sure.
Into the light a little bit so we can 6.5 days. How many days now?
Is the audio video clear?
6.5
Yes.
days. And
Hello.
Yes, sir, I can see now.
Yes, sir.
also noted
Yes.
on her hands. Is it just on her hands then?
It's on her hands and her feet.
Okay.
And
I'm going to
rash all
actually
over.
ask, would you guys move her out into the light a little bit so we can yeah, this is good. This is good. Okay. Hi, sweetie. And I'm just going to I'm going to try and capture her lips. Okay. And then as far as any like swollen lymph nodes on her at all?
Not really swollen lymph nodes. The rash also goes.
Let's see this rash.
From her neck all the way down to her growing area and across her stomach. The rash, like her hands, is also on her feet.
Yeah. Okay, so it's kind of a fine.
The back's worse than the stomach.
Papular type rashes. It's not really elevated. Really appreciate you letting us. Okay. Lymph nodes, I think. Shoddy means basically it's a term which I'm going to try and come around with my other hand to the front.
She also had the swollen eyes.
Got cracked and bleeding lips, is that right? And she's had a fever how many days now?
6.5 days.
6.5 days. And then you've also noted on her hands. Is it just on her hands then?
It's on her.
Shall we? Will we start?
That it was breaking in between. I could find out most of it, but I can try.
Would you guys
Okay, I'm
move
playing
her
again,
out into the
okay?
light a little bit so we can...
Is it streaming now?
So it's playing, but it is stopping in between.
Okay, I am played.
over and that is, let's see the other hand. Okay, and then as far as any like swollen lymph nodes on her at all?
Not really swollen lymph nodes. The rash also goes.
Let's see this rash.
Down to her growing area and across her stomach. The rash, like her hands, is also on her feet.
Yeah. Okay. And let's take a look at her back then. Really appreciate you letting us. Okay, all right. It's definitely not like a strep throat rash. Now let me just palpate for lymph nodes on her too. She has some shoddy little lymph nodes, I think. Shoddy means basically it's a term which I'm going to try and come around my other hand to the front here.
She also had the swollen eyes.
Yeah, her eyes, she's got cracked and bleeding lips, is that right? And she's had a fever how many days now?
6.5 days.
6.5 days. And then you've also noted on her hands. Is it just on her hands then?
It's on her hands and her feet.
Okay. I'm going to actually ask, would you guys move her out into the light a little bit so we can... yeah, this is good. This is good. Okay. Hi, sweetie. And I'm just going to I'm going to try and capture her lips a little bit here. And then let's turn her hands over. And okay.
Yes, sir.
All the way down to her growing area and across her stomach. The rash, like her hands, is also on her feet.
Yeah. Okay, so kind of a fine...
the back's worse than the stomach.
Papular type rashes. It's not really elevated. Okay, let me see her other foot too. Hey, sweetie. All right, and let's take a look at her back then. Really appreciate you letting us. Okay, all right. It's definitely not like a strep throat rash. Now let me just palpate. Let me just palpate for lymph nodes on her too. She has some shoddy little lymph nodes, I think. Shoddy means basically it's a term. I'm going to try and come around my other hand to the front here.
She also has the swollen eyes.
Yeah, her she's got cracked and bleeding lips. Is that right? And she's had a fever how many days now?
6.5 days.
6.5 days. And then you've also noted on her hands. Is it just on her hands then?
It's on her hands and her feet.
Okay. I'm going to actually ask, would you guys, so we can, this is good.
Yes, sir, we can start.
Yeah. Okay. Her hand. Okay. And then as far as any like swollen lymph nodes on her at all?
Not really swollen lymph nodes. The rash also goes
Let's see this rash.
From her neck all the way down area
Is it
and across
okay?
her stomach. The
Yes, sir.
rash like her hands is also on her feet.
Yeah.
Yes, you can start, doctor.
Yes, sir. So this video showed a tiny girl, probably like toddler age group girl, who is being wheeled into the hospital, sat on her mother's lap on a stretcher. It is a hospital setting, and the doctor is trying to examine her and take history. This child I could examine was probably well grown for her age and did not look dysmorphic. She looked a bit toxic. She had conjunctival congestion, and her lips were a little cracked and reddish. And then the doctor was examining her neck to look for any lymph nodes, and mom was showing some rash in the back and some on her tummy. It was all reddish and erythematous and widespread rash. And on examination of the hands, there were some swollen fingers and palmar erythema kind of picture, and even the toes were swollen, sir.
Okay. So what are the differences you like to offer from your observation of the video?
Sir, from my observation of video, my first differential would be Kawasaki's disease. Second one would be scarlet fever, or it could be any sepsis or COVID-induced PIMS. These would be my top 4 differentials, sir.
Okay. So how would you like to organize your history?
Sir, in history, I would like to first ask how the rash started and how all of the symptoms started, what started first, how it progressed, and then if they have given any medications at all for the symptoms, and how the child is activity, and is anybody else sick at home? Is the child going to nursery or school who had similar symptoms, or was the child having a vaccination previously, any post-vaccinations type? And I would also ask about feeding history, whether the child, that would be my history about the presenting symptoms. And then I would also ask how the child is now, how much the temperature is, how many days of fever, and how the child is hydrating herself. Is the child feeding well? And have they given any medications for the same, or if they've met any teams at all? Mainly this one, sir.
Okay. So what are allowed to examine this child?
Sorry, sir, your voice was breaking. Sir?
What are the things you like to
Sir, please could you repeat? I couldn't hear.
Yeah. What are the things you like to focus if you're allowed to examine this child?
Sir, I would like to see if she fits into the criteria for Kawasaki's or anything. So I would basically admit her and do a full set of observations, heart rate, respiratory rate, measure her temperature, and look at her hydration status. From head to toe examination, I would look for conjunctival congestion. I would look at her oral cavity, look for any strawberry tongue or any lips cracking or dermal rashes or edema, then I would see how the rash is, where it is progressed, and I would also examine her heart. I would listen to her heart, look for any tachycardia, get an ECG done, and then I would also look for any signs of failure or anything, sir.
Okay. Considering your potential of Kawasaki disease, how would you like to treat this child?
Sir, first I would admit this child. Probably this child would require multiple teams to be involved. I would involve my pediatric consultant. I would inform the cardiologist that this child is here. I would get a baseline ECG and echo done, because usually it will have coronaries involved. And I would ask, get their opinion and get IVIG arranged as well, because I need to suppress this child with IV that is immune mediated. So I would need to give her IVIG, and I would admit the child, put in a cannula, and send some bloods. I would like to do an FBC, CRP, ESR, and clotting as well. And use and ease, ECG and echo will be my first line investigation, sir. And depending on that, I would like to give IVIG and steroids, and start some aspirin as well, sir. High dose aspirin followed by low dose aspirin as continuation management.
Okay. Would you like to do an echo for this child? And when would you like to do that?
Sir, I think if possible, I would get an echo done early in the course of illness, probably soon after admission, because coronaries are involved and it causes problems then. So I would get an echo done as early as possible, sir.
Okay. In case the initial echo is normal,
I would repeat in 24 to 48 hours, sir, because most of the kids will show some signs of cardiovascular involvement, probably like tachycardia. Some might go to cardiogenic shock as well, sir.
okay. So when would you like to refer this child or get an opinion from pediatric rheumatology? Hello.
Sir,
Hmm.
probably I should do that early, sir. I'm
Okay.
not
Any
very
specific indications for pediatric rheumatology referral, or you told me that you like to start the child on IVIG and steroids and aspirin, right? So when would you like to get a opinion from pediatric rheumatology, or can you mention your team of management?
The team involved would be pediatric consultant and probably the ICU team, and then cardiologist, and if child is not responding to IVIG and having any joints involvement, I would call rheumat probably, sir. I'm not very sure of rheumat when I should call, sir.
Hello. Yes. Any specific advice you want to give it to this mother?
Sir, sir, I would tell them that this is an immune mediated reaction, so we need to give IVIG, and I would counsel them about IVIG, tell them how it acts and that it is a blood product. So about the risks and benefits of that, and get consent for the same. I would tell them that the child would need to have a close follow up, and the risk of bleeding and clotting associated with the medicines which we will be giving. And regular follow up will be needed for some time with echo and ECG as well, sir. And we would also monitor the immune response by doing CRP and neutrophil count, CBC. In the meantime, I would also tell them that we would need to rule out other infections like scarlet fever and rule out the other differentials, sir.
Okay. Right. Okay, Doctor. Thank you.
Thank
Time
you,
up.
sir.
Quickly, my feedback. The differentials, okay, your first differential should be Kawasaki, and then you told about viral. Maybe scarlet fever can keep it down, but I would want to add up drugs here. Okay, any medications, okay, any drugs side effects can cause this sort of rash. See, whenever you have a rash, always bring in viral rash and any drug-related rash into the differential. Okay, so these are very close differentials. Okay, so just include drugs also in your differentials of rash. And in the examination, maybe if it is an Indian center, then examination of BCG site. Okay, so that is also very specific for Kawasaki. So include that in your picture. And the management part, you should start with like admission, isolation, and don't start steroids upfront. Okay, steroids, you started the steroids in the upfront, so do not impose steroids in the management. The first choice is IVA as per the guidelines. Initially, it is high dose aspirin, and then it is maintenance dose. Okay, so after that, not
Sir, not audible. Not audible, sir.
so do not mention steroids upfront itself. Okay, you will start steroids only if there is going to be a high risk score. Okay, or if the child is not responding to IVIG. Second dose. Okay, so initially give one IVIG and then repeat after 72 hours. If still child has fever and rise active phase response, that is the time you will think about starting steroids. So don't mention steroids upfront in the management of Kawasaki.
Okay, sir.
Okay, and regarding the pediatric rheumatology referral, when there is going to be incomplete Kawasaki, when the diagnosis is difficult, or if it is an infant. Okay, so infants are likely to have incomplete and atypical Kawasaki. And as I mentioned, if there's going to be failed IVIG, when you decide to start steroids, then that's the time you would like to get an opinion from pediatric rheumatology. Okay, these are all indications. And advice is
Sir, no voice. No voice, sir.
good. So avoiding advice to the mother is avoiding live vaccines, avoiding strenuous activity, and follow up for 2 weeks and 6 weeks. Because sometimes when the echo is normal, then 2 weeks and 6 weeks echo is planned. Okay, so the final thing is at 6 weeks. And then depending upon the child has aneurysm, then the follow-up will be planned. So baseline echo at 2 weeks and 6 weeks are essential. Is that clear?
Yes,
Sir,
sir.
how will we describe the rash? What will we say? And what about about the hands? We will say
Yes.
swelling in the hand, redness. What
Yes.
should we
See,
tell?
here you are going to describe to doctor, right? So you can use medical terms. You can tell there is obvious edema, there is a rash, which is maculopapular rash, sort of macular rash, and it is distributed over the back as well as there's a red tongue and there is a red eyes. Okay, so there is a conjunctival suffusion there and there is a red lips and you see rash in chest, back and in the hands and there is a diffuse edema and erythema of the hands.
Yes, because there is redness also. Then we'll say erythema of the hands, right?
Yeah. Acute phase, there is erythema and edema in Kawasaki. Okay, and in the late phase, there is discommission. And all these nail changes, skin peeling happens at late, after 1 to 2 weeks.
So the desquamation occurs.
Any doubts with this video?
Thank you, sir.
Gotcha. Okay. Anybody else wants to try one more thing? One more videos we have.
I want to try it.
Yeah. Are you able to see the video?
Yeah. Yeah.
Right. Only video here, no audio. Okay.
Okay.
Yes, shall we?
Yeah.
That's true. Yes, Ruta, can start.
I can see a female with. I can see that there's a right hand in most probably home setting. I could not appreciate any facial features because it was not shown. And have no idea about the medical devices as well. But there are many hyperpigmented lesions on the arm, and there are some acne spots as well, and they're excoriated, most likely due to itching. And more, yeah, multiple sizes of hyperpigmented lesions.
Okay. So what are the differentials you would like to think with your observation from this video?
It can be confetti lesions of tuberous sclerosis,
It can be post-infectious hyperpigmentation, could be vitiligo as well. Hello?
What are the
Can you
questions?
hear me?
Okay. So quickly, what are the questions you would like to ask in the history?
I'm going to ask about onset course and duration of the illness. Other than that, I'm going to ask anything that increases or decreases it. And I'm going to ask about any previous lesions over here which were already present, and any history of any mental disorders. Other than that, I will also ask about any have blood pressure ever been checked, or sugar, and any rashes on the face, any hyperpigmented lesions like kephaloid spots, and any family history of similar illness, yeah, and any other
Okay.
skin lesions as well, any visual problems,
Okay.
any
So,
palpitations.
okay. So quickly, what are the differentials?
Confetti lesions of tuberous sclerosis.
Possible.
It can be post after some post-infectious post-inflammatory hyperpigmentation, and can be vitiligo as well.
Hello.
Yeah. I said it's confetti lesions of tuberous sclerosis, post inflammatory hyperpigmentation, and vitiligo.
Okay, doctor. Okay. Any other differentials you would like to add?
Any fungal infections.
Okay. So, what did you observe in the video? Like, can you describe the lesions again?
There were multi-sized hyperpigmented lesions, and there were some also most likely acne scars, and some eschar was formed on, and there was itching on them as well. That's why they were excoriated.
Okay. So you mentioned that you would like to ask about any psychiatric illness, right?
Yeah.
What?
So maybe maybe she made gave her some trauma, and after that they healed, and they healed in a hyperpigmented lesion. So that was my second differential post inflammatory, hyperpigmentation.
Okay. So let's skip this. Okay. So
No voice.
Is my connection? I can't hear you in between. Hello? Can you hear me?
We can hear you, but sir is having connection issue, I guess.
So
okay.
Yeah. Am I audible? See, if in the
Yeah.
setting that this is self-inflicted, how would you like to manage?
If it is self-inflicted, then
Yeah.
I'd like to involve psychiatrist and psychologist, and I will do cognitive behavioral therapy, habit reversal therapy as well. Discuss with her some triggers, what can be causing this, and try to um, make her do some other thing when she's having that stress illness, that is habit reversal therapy.
Okay. So when would you like to admit this adolescent?
If I think there is any chance of self-harm or suicide, then I will admit her.
Okay. Okay, doctor. Thank you. So quickly, my feedback, if you're going to describe this video, then you can tell about the different sizes and shapes, and somewhat it is present more in the exposed and reachable parts, right? And you see there are 2 or 3 spots with red marks, likely to be cigarette burns. Okay.
Yeah. Okay.
So those are fresh lesions, and other things are healed one. Okay. So this could be a sort of a coping behavior for some sort of stress, or it could be some inflicted by any of their close friends or anybody in the family, or sort of abuse as well. Okay. So either way is possible. So the thing is, the lesions are of somewhat circular and of varying ages, and it is in the exposed parts, and there are few lesions which are very fresh. Okay. So that's one, and accessible areas. Uh,
And they are hypopigmented, we will say hypopigmented lesion, right?
Focus will be on heads history, is it not? So
Yeah.
any bullying, how is the scenario at home? How is the scenario at school? Okay, and does she have any sexual partner? And all those things will be in the list. Okay. Management will be referral to management services.
Sorry, sir. What did you say?
Camps.
Management would be camps. Okay.
Services. Okay. And the most important thing I would like to hear from you is you will approach this child in a non-judgmental and non-confronting way.
Okay.
Okay, so that's how you start, how you approach this sort of patients with self-harm or sort of an abuse. Okay, so you will put your questions in a non-confrontational, non-judgmental way, and you will offer support, and your team should involve school nurse as well, apart from the dermatologist, psychologist for cognitive behavioral therapy, psychiatrist, consultant, pediatrician. School nurse is also essential here. An indication for admission will be, as you mentioned, social tendencies, or if there is any lack of social support. Okay, if there is no support in the family, or if there's a chance that she may get abused at the family level itself, then you may consider admitting this child, right? After discussing with your consultant.
So can you repeat the management?
Management, the approach should be non-judgmental and non-confrontational. Okay, and putting the adolescent at ease first. Okay, you will try to refer this patient to childhood and adolescent mental health services, where your team will involve the consultant pediatrician, along with psychiatrist, along with the dermatologist, along with psychologist and school nurse. Okay, and the focus will be on cognitive behavioral therapy. Okay, and you will liaise also with social worker if there is a chance of any abuses itself. Okay. And you will admit this child in a scenario that if she has a tendency to self-harm or suicidal intention is there, as well as that if there is no family support, then you will admit this teenage or this patient for further observation and further monitoring.
Sir, can you show the video again?
You want to play the video again? Yeah.
Yeah.